Yeah, you can enlarge the slide.
Yes, I'm.
Yes. Yeah, perfect.
So, dear Chairman, dear colleagues, thanks for the invitation. I'm happy to share with you today rather some molecular aspects on the mode of action of non-steroidal mineralocorticoid receptor antagonism. What you can see here on the left side is the classical textbook knowledge what aldosterone is doing in the renal epithelial distal tubule. And that is still from the year 2000, where you can see the acknowledged role of aldosterone mediating sodium transport. So until that time, 2000, I would say we had a rather renal epithelial centralized view what aldosterone is doing in the kidney. However, we had a substantial increase in the understanding of its pathophysiological role. What you can see here on the right side is a cartoon from the year 2015, where some authors summarized the current knowledge at that time about aldosterone in the heart and in the kidney, which is a rather systemic view, because it has been realized that in the meanwhile that aldosterone is playing a major role via its receptor, the mineralocorticoid receptor, also in inflammation and fibrosis. However, that is not so much new. I have to say that a far-sighted physician called Hans Selye, an Hungarian who moved in the 30s of the last century to Canada, already recognized that application of a precursor of aldosterone called desoxycorticosterone induced directly glomerular fibrosis in animals. And that was published in 1943. In 1955, so after the isolation and purification of aldosterone in 1953, he repeated some studies and summarized here in this nice review in Science in 1955 that aldosterone is both pro-inflammatory and pro-fibrotic. And he called aldosterone, in fact, pro-phlogistic. And that is remarkable for that time. That somehow got forgotten. It was not very much appreciated at that time, but there was a kind of rediscovery of the pro-fibrotic activity of aldosterone with a very famous clinical trial in heart failure done by Bertram Pitt called RAILS. That was published in 1999, and Bertram Pitt was quite convinced about the antifibrotic activity of aldosterone antagonism. And he did that, of course, with a very old and unselective compound, spironolactone, in patients with severe heart failure, as shown on the left side. Spironolactone given on top of standard of care at that time among patients with severe heart failure reduced mortality by fabulous 30%. However, due to the unselectivity of spironolactone, the very famous side effect, gynecomastia, was also present in about 10% of all men in this clinical trial. But even more importantly, as you know, the incidence of hyperkalemia associated with the use of spironolactone in real-world patients, as shown here in the middle of in this cartoon in the middle, dramatically increased after the publication of RAILS indicated by the SIN error. So that is the rates of hospital admission for hyperkalemia, and on the bottom, even death for hyperkalemia associated with spironolactone. And as you know, we have a second steroidal mineralocorticoid receptor antagonist as a successor of spironolactone, that is eplerenone. And eplerenone is even contraindicated in patients with type 2 diabetes and macroalbuminuria due to the fact that a lot of cases of hyperkalemia happened in a phase 2 trial with eplerenone in diabetic patients. So neither spironolactone nor eplerenone are indicated for the treatment of CKD. As mentioned before, more and more scientific investigators, preclinical investigators, tested nevertheless the role of aldosterone and MR blockade in animals. And that here is a nice summary on the left side by Remuzzi from Bergamo, who in 2008 summarized the current knowledge about what aldosterone is doing in the kidney beyond sodium-potassium exchange. Inflammation, hypertrophy, extracellular matrix, and cell proliferation, leading to glomerulosclerosis and tubular interstitial fibrosis. That was very nicely summarized in Jason. We have extended this view a little bit, changed from just aldosterone rather to the receptor itself. So the mineralocorticoid receptor, which is not only activated by aldosterone, but also by cortisol, and expressed in many different cell lines, in different organs. And upon activation of this receptor, which is basically a transcription factor, driving gene expression in a cell type specific manner, either in the renal epithelial tubule, controlled sodium and potassium, but in all other cells. And I have to highlight also here immune cells such as monocytes, drives inflammation and fibrosis. So these animal studies, summarized before by Remuzzi, then led to some first clinical trials in patients with CKD, with different types of nephropathy, summarized here from a review in Kidney International from 2011. And these trials were rather small, as you can see from the numbers of the patients, and rather short, up to 12 months. But the common picture, the outcome of all these trials was that MR antagonism by spironolactone reduces in all trials proteinuria, which is of course an important biomarker in CKD. And if we pick out a single trial here, one of the larger trials done by Bianchi in 2006 with 165 patients having a GFR about 62 milliliter per minute and a serum potassium at baseline of 4.2, were treated with 25 milligram per kilogram of spironolactone for 1 year. You see that after 1 year, there was a robust reduction in proteinuria, whether patients had a GFR below 60 or above 60. So there was a clear reduction in albuminuria and proteinuria. However, that is coming for a price. And as you see on the right side, only in the spironolactone arm, on top of RAS blockade, serum potassium increased by 0.8 millimolar. And that is substantial. And that is, of course, due to the fact that spironolactone acts very efficaciously on the distal tubule, acting on the sodium-potassium exchange, also especially in patients with type 2 diabetes and CKD. And that was the reason why several pharmaceutical companies initiated screening for novel non-steroidal MR antagonists in order to identify new pharmacokinetic and pharmacodynamic profiles and overall an improved benefit-risk ratio. And that is here the in vitro profile of Phenerenone. Phenerenone, or formerly known as B948862, is at least as potent as spironolactone in vitro. The selectivity, however, is at least 500-fold. So we have not observed any affinity with the other steroid hormone receptors, And in contrast to spironolactone, which is also a very potent androgen receptor antagonist and a progesterone receptor agonist, which is the reason, I mean, the antagonism of androgen receptor for the gynecomastia, Phenerenone has no affinity. Phenerenone has also no affinity for the most relevant 65 cardiovascular receptors and ion channels up to 10 micromolar. So it is a very highly selective and potent MR antagonist. And it is not everything about potency and selectivity. It's also about the fact that it is a non-steroidal compound. It has totally new physicochemical properties as shown here on the left side. So it is more polar, less lipophilic in contrast to the steroidal antagonist. And this has major conclusions on these physicochemical properties on transport, distribution, and tissue penetration. So Phenerenone, for example, is equally distributed between the heart and the kidney, and that is in contrast to the steroidal antagonist, which accumulates in the kidney. Phenerenone contacts totally different amino acids within the MR receptor, as have been found in the groups of Marie-Edith Ravstan-Aublan and Marc Lambès in Paris, in France. And this cartoon here on the right side shows that Phenerenone is a so-called bulky antagonist. This bulky antagonism, based on its basically dihydroprotein structure, induces a different conformational change within the receptor, which is then unable to recruit important cofactor as a transcription factor. And I've here on this slide summarized for you from a review which has just been accepted by the British Journal of Pharmacology, differences between steroidal MRAs and Phenerenone based on the structural properties. So spironolactone and eplerenone are as aldosterone flat steroidal compounds. Phenerenone is bulky, leads to a different conformational change within the receptor, is most potent and selective in this combination, does not penetrate into the CNS in contrast to the steroidal antagonist, does not have had any sexual side effects such as gynecomastia, has a remarkable short half-life of only 2 to 3 hours, has no active metabolites in contrast to spironolactone, which has several long-acting metabolites, and interestingly, a rather moderate and very small effect on blood pressure so far in clinical trials. And if I now finalize with the mode of action that is summarized here in this cartoon, also taken from a recent review in pharmacological research, due to this conformational change in the receptor, which is then unable to recruit cofactors, Phenerenone blocks in the kidney, as well as in the heart, as well as in recruiting cells, such as fibroblasts and macrophages, gene programs which are driving in particular inflammation and fibrosis. And that is blocked by Phenerenone. So I hope I could take you with me on a small journey starting from the physiology, which is known from the textbook until 2000, the renal epithelial centralized view, over the systemic view on inflammation and fibrosis, until the pathway, the differential pathway utilization by novel non-steroidal MR antagonists. And if you would like to read more about that, I highly recommend this most recent review by Rajiv Agarwal in the European Heart Journal, which has been appeared recently. So with that, I would thank you for your attention and looking forward to the discussion.